Hello everyone. So now we will continue our discussion on vaginal infection, vaginitis. So we were discussing about candidiasis. We had already finished trichomoniasis. So in candidiasis, we had already discussed that the causative organism is Candida albicans. The risk factor for the candidiasis are diabetes, pregnancy, broad spectrum antibiotic, combined oral pill, immunosuppression drug, and thyroid, parathyroid, obesity. So the clinical feature of candidiasis are intense vulvovaginal pruritus. The the itching is very much prominent than discharge. It is a special feature of this candidiasis that itching is more prominent than discharge. So there can be dyspareunia due to local soreness. So on examination, we can see that the discharge of in the candidiasis infection is thick, cordy white, and in flakes. They have the cottage cheese X type and often adherent to vaginal wall. They are adherent to vaginal wall. They are thick, cordy white, whereas the vaginal discharge in candidiasis was thin and grey or yellow type. The vulva is red swollen. The vaginal examination is tender. We can find there is tenderness and atrophy of vulva-vagina is there, especially in the postmenopausal women. And special feature is the pH in the Candida infection is the discharge as pH less than 4.5, whereas in Trichomonas vaginalis discharge is greater than 4.5, and also in the bacterial vaginosis the pH is greater than 4.5, whereas only in candidiasis it has less than 4.5. That means Candida grows in the acidic environment. On weight mount examination, we can see the pseudo hyphae of the Candida. In the weight mount, we have to add a KVH solution is added, 10% KVH solution to destroy the RBC, lyse the RBC. Now on the pap smear examination, the hyphae can be identified. The spores are smaller than nucleus of epithelial cell, and there is shish kebab appearance, just like the real shish kebab, like the one stick with the paneer in the middle. So similar, this type of appearance occurs in pap smear examination of in Candida. And the culture, we can do the culture in the culture media like Sebrose, dextrose agar. We can do culture in Nicholson or Sebrose dextrose agar media, and culture becomes positive in 24 to 72 hours, and we can find that the whiff test is negative. Whiff test is negative in Candida, and whiff test was also negative in Trichomonas vaginalis. So that was all. And the treatment of the Candida infection, we have to do the correction of underlying factors. Predisposing factors should be treated, and we can do the local intravaginal fungicidal cream like vaginal cream or pessary of the nystatin, clotrimazole, miconazole, torcanazole, or alternatively we can use fluconazole 150 mg oral OD stat, fluconazole 150 mg orally in uncomplicated vulvovaginal candidiasis. What do you mean by uncomplicated vulvovaginal candidiasis? It is the infection where that is sporadic type, that is mild or moderate in severity, and it is mainly uncomplicated infection is mainly due to Candida albicans, and it occurs in non-immune compromised women. Uncomplicated vulvovaginal candidiasis occurs, whereas complicated vulvovaginitis means that the infection is recurrent, severe, and the non-albicans Candida has the infection, non-albicans Candida, uncomplicated by Candida albicans, whereas complicated vulvovaginitis is caused by other Candida than Candida albicans, other species of Candida, and in the women with uncontrolled diabetes and with the suppressed immune system have this the complicated vulvovaginitis. So these are the different treatment modality. For uncomplicated, we have the topical antifungal agent for 1 to 3 days. single oral fluconazole or itraconazole, as we have already fluconazole 150 mg. And for the complicated vulvovaginitis, we have topical azole 2 doses for 7 to 14 days, oral therapy a second dose of fluconazole 150 mg 72 hours after first dose. We have to do 2 doses. And vaginal boric acid capsule can be used. The vaginal boric acid capsule with the gelatin capsule. This boric acid inhibit the fungal cell wall growth. So that was about the candidiasis. Now we will see about bacterial vaginosis. The causative organism of the bacterial vaginosis was previously thought to be Gardnerella vaginosis. The present concept is that along with Gardnerella vaginalis, there are even other bacteria, other anaerobic bacteria like Bacteroides, Peptococcus, Mobilincus, Prevotella, Mycoplasma hominis. These bacteria can cause bacterial vaginosis. And the creamy vaginal discharge with fishy smell. On examination, there is creamy vaginal discharge with fishy smell. That is very characteristic, fishy smell. And there is especially there is no pruritus, dysuria or dyspareunia. It is a special feature, you have to note it. Pruritus is very intense in candidiasis, whereas there is some itching is also present in trichomoniasis, whereas there is no itching in bacterial vaginosis, and there is no dysuria, no dyspareunia. And risk factor for the bacterial vaginosis are multiple sexual partner, cigarette smoking, IUCD use, immunosuppression. Cigarette smoking, IUCD, immunosuppression, these are the risk factor for bacterial vaginosis. And what are the complications of bacterial vaginosis? We have recurrent infection leading to pelvic. Other complication is development of pelvic inflammatory disease following abortion, vaginal cough, cellulitis following hysterectomy. There can be pregnancy complication like second trimester miscarriage, premature rupture of membrane, preterm birth, and endometritis. These are the complications of bacterial vaginosis. Pregnancy complication. These are the pregnancy complication, and these are other vaginal cough, cellulitis, development of PID following abortion, recurrent infection leading to PID. So these are about complication of bacterial vaginosis. On examination, what can we find is it is malodorous vaginal discharge. The vaginal discharge is malodorous. It is grey white in color. There is no vaginal inflammation. This is especially we have to note that there is no vaginal infection. That's why it is called bacterial vaginosis. We don't call bacterial vaginitis. We call bacterial vaginosis because there is no vaginal inflammation. The discharge is homogeneous, greyish white, and they are adherent to vaginal wall, and the pH is 4.5, greater than 4.5. And on wet mount examination, we can see the clue cell. This is very characteristic feature. We can find the clue cell. The smear of vaginal discharge is prepared with drop of normal saline on glass slide, and it is seen under microscope. The vaginal epithelial cell are seen covered with these cocobacilli, and the cell appear as stippled or granular. The vaginal cell are seen covered with these cocobacilli, and they are stippled or granular. At times the cell are so heavily stippled that the cell border are also obscured. These stippled epithelial cell are called clue cell. The presence of clue cell greater than 20% is the one diagnostic of bacterial vaginosis. And on gram staining, we have the Nugent score 7 to 10, and on whiff test, finally the whiff test came here. The fishy amine order, we get fishy amine order when we add the drop of this. When we add a drop of KOS, drop of 10% KOS solution is mixed with discharge. So let's listen it again. When we add a drop of vaginal discharge in 10% KOS solution, we get fishy amine order. That is known as whiff test, and it is one of the component of AMSIL criteria. What is the AMSIL criteria? MCEL criteria is used for presumptive diagnosis of bacterial vaginosis. It has 4 different criteria to diagnose bacterial vaginosis. One is homogeneous vaginal discharge. Second is vaginal pH greater than 4.5, seen through the litmus paper test, and the positive whiff test and the presence of clue cell greater than 20% of cell. Homogeneous vaginal discharge, vaginal pH greater than 4.5, positive whiff test, and the presence of clue cell greater than 20% of cell. These are known as MCEL's criteria. And that finally we have the treatment part. The treatment of bacterial vaginosis is same as trichomoniasis. Same, that is metronidazole 500 mg oral twice a day for 7 days. We can use that, or we can also use clindamycin 300 mg twice a day for 7 days. This we can remember this one, metronidazole. This is same as trichomonas vaginalis, and the sexual partner is treated simultaneously in bacterial vaginosis. So that was all about 3 important differential diagnosis of bacterial vaginosis. Bacterial and 3 differential diagnoses of vaginal discharge: trichomoniasis, candidiasis, and bacterial vaginosis. There are 3 causative organisms, easy to remember. There is pain and discharge. Intense pain is itching is more prominent than discharge. Discharge with fishy smell. Again, these are the different characteristics of discharge that we can differentiate by pH. pH is less in Candida, whereas other greater in other trichomonas and bacterial vaginosis. These are different diagnosis. We can follow different modalities. The saline microscopy test, pap smear, gold standard investigation is culture, and for gold standard is gram staining in bacterial vaginosis. This is whiff test and all this treatment part. So that was all. So if you are interested, then you may screenshot this note. I will put it. You can screenshot this note, and this may be helpful for you. So that was all about bacterial vaginitis. That was all about vaginitis, or the important topic of gynecology. So next time we will come up with some other topic, the other important topic of the gynecology. So thank you for until that time, keep revising and still learning. Thank you.